topic I will talk about is the transcatheter pulmonary valve replacement. You know that the pioneer experience in this field was performed by Philip Bonhoeffer back in 2000 when the first percutaneous valve was implanted in a patient. Then the device that you are aware of, that's a Melody, has been widely spread and in all over the world, and nowadays more than 4,000 patients have been treated by Melody device. The target population we are talking about is represented by a variety of patients with conotruncal malformation mainly, who previously underwent 1, 2, or 3, or even more surgical acts to replace in the continuity between the right ventricle and the pulmonary artery by surgical conduits. The device is represented by a piece of jugular vein, which is sutured on a CP stent and can be crimped down to a small size to be inserted into a catheter and over a bib balloon re-expanded up to 18, 20, or 22 millimeters. And the original and standard use of this device is to extend the functional life for a conduit, RVOT conduit, abolishing the obstruction and without inducing pulmonary regurgitation. Just a slide to stress the importance of patient selection and the importance of the MRI, which is the most important imaging tool to assess the morphology of the right ventricular outflow tract and select the patient properly. This is an example of an MRI with an obstructed conduit with 3D reconstruction, which is also very useful to get a rough idea of what the anatomy is before attempting doing the procedure. And of course, the pre-procedural imaging must match the angiographic pictures that we can obtain in the cath lab. In some cases where MRI is not feasible, the CT scan can also be used and is seen in the example where a 3D reconstruction of CT and the angiogram done in the cath lab. Very briefly talking about the procedure, prestenting is used almost in all patients due to prepare a good landing zone, for example, in this particular patient, post-dilating the stent with a high-pressure balloon, and to facilitate and give the ideal position to put the Melody in. And in addition, prestenting has been demonstrated to be useful for preventing stent fracture during follow-up. And this, the Melody implantation, full expansion of the inner balloon, outer balloon, and that's the immediate result showing a perfect competence of the valve. Well, we can treat several types of conduit obstruction. This is an example of a distal conduit stenosis, and that's immediate result after Melody implantation. Sometimes the conduit is, the stenosis is very complex. This is an example of very tight and long stenosis where multiple stents were implanted for preparing a good landing zone before implanting the Melody. So we have to adapt the technique to the characteristic of the anatomy of the patient. To the opposite end, this is a non-stenotic but purely regurgitant calcified homograph that you see on MRI and angiogram. And in addition, there is a stenosis of the left PA that was stented first and the Melody implanted with the excellent immediate results. So even more complex cases where multiple disease or pathologies has to be treated in the same time. Bioprosthetic valves as well can be treated in the cath lab when malfunctioned. Well, actually, it's even easier because we have a rigid landing zone, and we don't need to do Prestenting in this case. This is a melody that is implanted in a procedure that we may call valve-in-valve. You see an inflation, full expansion of the valve, and immediate results showing a perfectly competent valve. This is another example in a patient who had a repair, put in a bioprosthesis, leaving the native outflow tract in place because of anomalies of the coronaries. The bioprosthesis became regurgitant, and that's the melody implanted, restoring the competence of the pulmonary valve. Well, around the world, more than 4,000 patients were treated with the melody device, but we discuss about only the studies reported in literature, the preliminary London experience, then the melody US trial, the German experience, and the Italian registry. Well, uniformly in all this experience, there was a significant reduction in the right ventricular to pulmonary artery gradient. So this device and this procedure can relieve the obstruction very effectively. And it can relieve the regurgitation as well. This is a result from the German experience, almost no regurgitation after the procedure. And the same results can last during the follow-up. This is the long-term experience reported by Philip Dourth some years ago in the preliminary London experience. So the melody valve is competent in almost 100% of the cases during follow-up as well. Well, the same results has been reported by McElhinney for the US experience. The valve is competent very nicely during follow-up, and that's the same results as well in our own experience. I mean, the competence of the valve is not a problem, not immediately and not during follow-up. Well, the patients are doing well. There is a symptomatic improvement in the majority of the patients, either for the patients treated for stenosis or regurgitant, or a combination of lesion. This is from the clinical point of view. But we will see that the remodeling or improvement of the right ventricular volume and function is more pronounced in patients with stenotic lesion as opposed to regurgitant lesions. And this is an important point to be taken into account for the managing the patients, the large amount of patients with pure pulmonary regurgitation, and we'll see in a second. Of course, there are some complications. This is overall complications, these 4 studies, around 6%. I don't want to go in detail on all these complications, but I would like to stress the 2 major complications that may occur: the homograph or conduit rupture and the coronary compression due to the stent implantation. I think these are the 2 most important complications that may occur. Well, this is an example of a heavily calcified conduit here, approach from the jugular vein, prestenting, melody implantation, excellent results as you see here with good hemodynamics. But if you look carefully at these 2 pictures before and after implantation, you see there is a crack on the calcium. Well, with no consequences at all in this particular patient, but this is, of course, a possible worrisome problem. When you inflate a balloon within a rigid conduit, actually you don't dilate the conduit, you crack the calcium. So you have to take into account this. So how to prevent the possible conduit rupture? Well, in my opinion, prestenting with cover stent may be a solution or may reduce significantly this risk, at least in a subset of so-called high-risk patients, represented, for example, for patients with tight stenosis and heavily calcified conduit. Well, this is an example. In our experience, a complex transposition with Rastelli with, you see, heavily calcified and tight stenosis of the conduit, massive calcification of the patch as well. Well, what to do this? Well, the decision was to pre-stent this conduit with the cover stent. You see the balloon is inflating, but the stent is not fully expanded. There was a tight stenosis, of course, here. However, looking at this incomplete stent expansion, but taking into account that this is a cover stent, we could post-dilate the stent with a high-pressure balloon, achieving a substantial increase in diameter of the stent and eventually implanted the medulla successfully. Well, coronary compression. This is pioneer experience reported by Philip Bonhoeffer, where LAD was completely occluded after implantation of the stent. Luckily enough, in this particular case that probably Neil Wilson is well aware of, after chest compression, it was strong enough to squeeze the stent and restore the flow in the left coronary. Of course, we have to avoid this complication, and that's why it has been introduced routinely, I would say, in the clinical practice to do a balloon inflation test with simultaneous aortogram or coronary angiogram to rule out the possibility of coronary compression. This is a patient that occurred in our experience with tight stenosis of a distal contegra conduit that seems to be suitable for stenting and device implantation. We did a balloon test and the aortogram. As you see here, the flow in the LAD completely disappears when the balloon is inflated. And deflating the balloon, the flow in the left coronary reappears. So no problem, of course, in this particular patient, but implanting the stent would have been a disaster, of course, in this particular patient. So this has to be careful to deal about this possibility. There are limitations for the melody because we don't know whether in right ventricular outflow tract reconstruction without a conduit can be used, or in RV outflow tract larger, significantly larger than 22, or generally in unfavorable anatomy for securing stent anchorage. Are there any alternatives? The answer is yes, to some extent. The Edwards Sapien valve, which is available in larger sizes, 23, 26, and more recently in 29 millimeters, so that theoretically can be used in larger size RV outflow tract. Well, this is an example of a calcified homograph that could have been treated with melody as well. This is a Sapien 26 millimeter implanted after pre-stenting, of course. You see this Andra Stent. It is important to perform a very slow inflation of the balloon to implant the Sapien, and this is the immediate result with good competence of the valve. Another example of a malfunctioning bioprosthesis where a Sapien 26 was implanted, as you see here, slow inflation without pre-stenting. We may discuss about that. Excellent result immediately. There is no need of pre-stenting. However, we have to be very, very careful in the precise location. Otherwise, you take a risk of dislocation of the valve. So in conclusion, when to use melody or Sapien? I think in conduits between 20 23 millimeter in size, both devices can be used successfully. In larger conduits, the Sapien has to be used because melody cannot be implanted in at at least following the recommendations of Medtronic, up to 22 millimeters, in spite of the fact that we can reach the size of 24 probably without problems. That it was even in a bit larger device. I would prefer certainly the melody in severely stenotic conduits, like an example I show you, because the melody valve, the valve in the melody device works at all sizes, even if the stent is not fully expanded, is not completely symmetric, the valve is working properly. As opposed to Sapien, when you have to achieve a full expansion, achieve a round shape for achieving a proper function, because it is not a native valve and is a tissue engineer valve. So you have to achieve a full expansion and round shape. Well, is pulmonary replacement feasible in native right ventricular outflow tract? Well, the answer is yes, but only in carefully selected cases. This is a peculiar example in our experience when a tetralogy was repaired, leaving the native outflow tract in place and put in a conduit because of anomalies of the coronaries, and the native outflow tract became insufficient, and the melody was easily implanted in the native outflow tract with excellent result. This is another example of a transannular patch repair of tetralogy. You see a very large RV outflow tract, pure regurgitation, no stenosis, but you may see an indentation there where theoretically can be hold the device in place. A balloon interrogation demonstrated a tiny waist where the calcification was, and therefore we attempted to put a stent there, expanded up to 27 millimeter. There is a residual indentation in the stent where it was possible, as you see in a second, to advance the sapien valve, which is expanded within the stent. Again, inflation of the balloon, which is very, very slow. I think this is very important to implant this valve, achieving a full expansion, well opposed to the previously implanted Andra Stent, and that immediate result, restoring regurgitation, restoring the competence in a native outflow patch repair. But you have to select the patient carefully. Well, in summary, the percutaneous pulmonary valve implantation leads to symptomatic improvement in all patients, in the vast majority of patients, regardless of the type of the lesion treated, stenosis or regurgitation. However, the adaptation and improvement in right ventricular parameters are certainly more pronounced in patients having stenosis instead of pure regurgitation. That's why patients with pure regurgitation may be treated before reduction in right ventricular function, or to prevent irreversible deterioration of the right ventricular parameters. But how can we treat very large, purely regurgitant lesions? So the native large RVO3, this is the challenge for the future. Well, a preliminary experience with the Medtronic infundibular reducer, or whatever you call it, a new device with self-expandable with hourglass shape, actually was implanted in January 2009 as a first-in-man experience in London by Philip Bonhoeffer, and I had the chance to take part with him in taking this procedure. You see the balloon demonstrated a huge RV outflow tract and PA, and the device implanted with good result. We were very happy about these results as well, and after 3 years the patient is doing well again. So we are very happy about that. And the program of, from Medtronic is underway to go ahead with this new device for treating patients with previous surgery with transannular patch, mainly with pure regurgitation, a very, very dilated main PA and right ventricular outflow tract. And there are also other devices that are in the way to address this problem, and this subset of patients that are actually more common than the patient having had an RV to pulmonary artery conduit. So there is a need to have a device that is going to be able to treat, avoiding repeated surgery, this particular patient. Thank you very much for your attention.